We'll move on to the next presentation on post-fever retinitis, the many phases, by Dr. Ankush Kawali. He is a senior uveitis consultant from Narayana Nethralaya, Bangalore. Over to Dr. Ankush.
Yeah, thank you. So I'll be mainly discussing the presentation, the various clinical signs, and the various etiologies. So the term post-fever retinitis or epidemic retinitis is an umbrella term which describes this peculiar retinitis entity which has been associated with various etiologies like chikungunya, dengue, West Nile virus, rickettsia, and even typhoid. Patient generally give a history of definitive fever 2 weeks to 4 weeks ago. They can come with this kind of skin rash and many times joint pain as well. The lesions of retinitis in this entity, they are mainly located at the posterior pole. They can be around the disc like this. They are mainly cortical spot-like retinitis lesions. They can be along the arcades. Retinitis lesions can be associated with severe macular edema, and when they start resolving, one can see this kind of macular star or macular fan formation. Lesions can be focal or multifocal. We have recently described this ring retinitis, which can occur in mid-periphery in almost 10% of patients in this particular study. This is a case which was treated only with steroid without any antibiotics, and we noted the migration of this retinitis lesion towards the macula. When the retinitis starts resolving, this kind of subretinal yellow dots can be seen, subretinal precipitates. They can be numerous and can be confusing with the syphilis as described by Dr. Mudit, or a lymphoma as well. And this is OCT scan which shows the exact location. OCT is more important. You can see the inner retinal hyperreflectivity with backshadowing and subretinal fluid, outer retinal edema, but you never see necrosis on the OCT scan in this particular entity. When it resolves, one can see hard exudates in the layer of Henle. Many times subretinal exudates can be seen, and this is again a rare occurrence of subretinal fluid in this entity. This sign we have recently seen. This patient just presented 2 months back, and at this area the patient had retinitis lesion, and when it resolved, the appearance like this crumple shaped of retina, if you can see here. And when we did the OCT scan, we discovered this newer sign which has not been noted earlier. But this particular sign has been described as a vertical hyperreflective lesions in a patient of lymphoma. Well, this patient is still under follow-up. We'll know how the lesions behave over a period of time. Coming to FFA, the vasculitic leakage or staining can be seen at the site of the retinitis lesions. And many times you detect NVE, even in absence of significant CNP areas. CNVM, I have not seen myself, but there are reports as well as this patient from my colleague, which was treated with anti-VEGF and it resolved. Coming to anterior segment, yes, we do see anterior segment reaction, but never hypopyon. Out of 350 cases what we have, these are the only 2 cases which had trace hypopyon. Now coming to etiology, we have many phases for etiology as well. This is the first series which we published of 10 patients presumed to be rickettsial retinitis because the diagnosis was based on Weil-Felix test. But subsequently there was another series from Arvind Coimbatore in which they have done the not only Weil-Felix test but also ELISA for rickettsia conryei. And as you can see here, the last 4 patients which are tested negative for Weil-Felix, but they were positive for ELISA. So this means that negative Weil-Felix test does not rule out rickettsia etiology. So next was our largest series of epidemic retinitis, in which we noted that most of our patients tested positive for Weil-Felix test, followed by IgG dengue, and followed by chikungunya. We also noted in this series that many patients, they had multiple positive investigation, like patient tested positive for Weil-Felix as well as for Vidal. Some patients were positive for chikungunya IgM as well as showed very high titers of dengue. And then there was this major article which has proven the etiology with using the gold standard investigation, the etiology of West Nile virus. But subsequently, we didn't see any reports on this. Similarly, there are a small series of chikungunya and dengue as well. Few authors tried to hunt down the organism by using even next generation sequencing. So they have isolated multiple organisms, but none which can explain the occurrence of fever or skin rash or joint pain. So we'll try to look at the other side of the coin by studying the seasonal variation of this disease. And we use this integrated disease surveillance program and noted that we compare the graph of epidemic retinitis with the graph of other outbreaks which occurs in the community. To our surprise, not a single graph was coinciding with this particular entity. But again, this IDSP registry did not include the outbreaks of rickettsia and West Nile virus. The study was done in 2015. So recently, I noted that they have started including rickettsial disease. During pandemic, various authors correlated this entity with the COVID-19. But when we studied the epidemiology as well as the seasonal variation, the study did not support the etiology of COVID with this particular entity. To our surprise, there was a report from Bangalore itself when the authors studied the seasonal variation of rickettssial fever in children, and the graph correlated with our graph of epidemic retinitis, suggesting the possibility of rickettssial disease as an etiological agent for the epidemic retinitis. We have various phases for treatment as well. We try to compare various treatment modalities, and we try to compare in our various publications the rate of resolution for macular edema and retinitis, and we noted no big difference as far as the resolution rate is concerned, whether you treat this patient with steroid or without steroid, treat with anti-VEGF or without anti-VEGF. But I can say one thing, that the patients resolve very well even if you treat them only with doxycycline, with topical steroid or even NSAIDs. One more hidden phase of this entity is visual fields. So even after a complete resolution of retinitis, one can see this kind of scotomas, which can persist for long. So this, in this particular case, it was more than 6 months. But I have cases in which the scotomas were permanent, even after resolution of the retinitis lesion. So my 5 take-home points. Once you see the patient who has been diagnosed by physician as a dengue, typhoid, or some viral fever, the patient gives history of skin rash or joint pain. The patient comes to with focal or multifocal, but non-necrotizing retinitis, with or without macular edema, formation of macular star. Do suspect epidemic retinitis. If you do the OCT scan, it will show inner retinal hyperreflectivity, ONL edema, mild NSD, but no necrosis. Do the baseline blood workup. If you are interested in knowing the etiology, do Wileflix test, typhoid, viral, chikungunya serology, or dengue serology. But if you notice the dramatic response to the doxycycline, even with or without steroid, that may prove the diagnosis of epidemic retinitis. Thank you.